So, good evening, everyone. I'm Dr. Purnima Sonkamre, and on behalf of ISA Mumbai Metro Branch, President Dr. Shweta Salgaonkar Madam and Secretary Dr. Sohan Solanki Sir, I welcome you all for today's webinar on remote anesthesia, or we can call it out of operating room anesthesia, or more popularly or scientifically known as non-operating room anesthesia, that is NORA. Now, demand for NORA has skyrocketed in the last 2 decades, and delivering anesthesia outside our comfort zone has many challenges. So, we will discuss these challenges and how to overcome these challenges in our today's academic activity. For ease of understanding, we have divided this webinar on what we can say, topics, that is anesthesia in the radiological suite and anesthesia for non-radiological suite. So for the first session, that is anesthesia for radiological suite, uh, I request Dr. Sohan Solanki sir to chair this lecture. He is a professor at Tata Memorial Hospital, editor-in-chief of Airway Journal, which is an official journal for All India Difficult Airway Association. And importantly, he is secretary of ISM Mumbai Metro Branch. So over to you, Solanki sir. Please introduce our speaker, Dr. Gauri Madam.
Thank you, Dr. Purnima, and welcome all to this ISM Mumbai Metro Branch webinar. And this webinar is in very demanding situation, the NORA, which is very fancy suits for the radiologist, but not very fancy or very not really comfortable for the anesthetist. And the same is the MRI suits or your medical GI suits or other some out of the operating room like anesthesia services. So to talk on this, I would invite Dr. Gauri Ganga Khedkar. So she is our associate professor in ACTEC at Tata Memorial Center, and she is very young, dynamic, and very well read about this subject, and she is really a good speaker. So Gauri, welcome.
Thank you so much, sir. That was really, really kind coming from Sohan, sir. That is high praise. I thank SAMS and ISA Mumbai Metro for this opportunity. And without wasting any further time, I would like to start my talk. So, like Purnima Madam said, today we're going to talk about anesthesia in NORA, that is non-operating room setups. And we've tried to divide the session into two parts. One is the radio-focused interventions, which I'm going to be looking at, and the other is the non-radio-focused interventions, which Vaishali Madam will cover. Why is this the focus on non-operating room anesthesia? Like Purnima Madam said before, this accounts for about 40% of our workload. And this workload is only going to continue to increase. There is a twofold higher mortality in NORA, and ASA close claims data suggests that more than 50% of the deaths that occur in NORA occur because of substandard anesthesia care. Now, these were preventable simply by improving monitoring techniques. I believe the scarier statistic is that of these claims, 50% of these claims, the anesthetic technique was monitored anesthesia care only, which meant that our intervention was the least, but the situation evolved in such a manner that we lost a patient. This is scary indeed. And this is even more serious because there's a serious underreporting of events always. We understand that only about 33% of these incidents are reported. So clearly the number is larger and we need to focus on NORA to make it safer. When we think about NORA, we have to realize that all the specialties involved in NORA are dynamic and rapidly evolving. They provide critical services to patients by providing an amalgamation between traditional surgery and modern medicine. Now, these provide minimally invasive alternatives to big problems, which could either not be addressed through conventional surgery, or maybe the surgery required was too extensive. Like we've discussed before, there's an ever-widening scope. If you ask 5 years ago what we did in Nora and what we do today, it is a huge difference, and the footprint in Nora is only increasing. And so is the range of indications. If we look at the scope of services that you simply provide for Nora, you can see this number. And all of these locations require your presence as an anesthetist. And as you can see in my attempt at a cartoon before, you are always required, always in demand. And each of these situations comes with unique perspectives and unique challenges. For my talk today, I'm going to be focusing on locations where radiation is involved, which would include pain, Nora for radiation oncology, and Nora for radiology. Just for the ease, I have also included MRI in my talk. The rest will be covered by Vaishali. If you have 100 problems, if you have 100 locations where you cover, you will have 100 problems. And if you are in a campus like ours, you're going to be stuck in different corners of the hospital and providing anesthesia at all of these locations. And these are simply just a list of all the problems that you face every time you attend a Nora location to try and provide safe anesthesia for the same. You're too far from everything. It is just too noisy. The workspace is too small. The lighting is not adequate. Thermal regulation is a problem. Everything interferes with what you want to do. Equipment is old. People are new. And there is limited patient access. So when I thought about how we could go about such a vast topic, I thought that, this is a learned audience. Most of the topics we already know. We know how to keep our patients safe. What we need to figure out is how to keep our patients safe in each of these locations. So I came up with a concern cheat sheet. For each of these locations, I have tried to focus on safety from the aspect of patients, what our priorities need to be, how we need to arrange the personnel, and what we do for preparation. That is the 4 Ps. Even amongst that, I realized that patient, preparation, and radiation were largely common to most of these specialties, so I will address all of them together. When we talk about patients, we have to realize that Nora procedures are usually done in patients where the procedure is either urgent or it is a diagnostic procedure, so further therapy cannot be planned unless this procedure takes place. So these patients often come to us inadequately optimized, or they've had inadequate preoperative evaluation and risk stratification. A lot of these procedures are performed as daycare cases. And to add to that problem, you have frail patients, you have the elderly, you have extremely sick patients who would not tolerate major surgery, and you have the little ones who are always full of surprises. We agree that these procedures are minimally invasive, but the anesthesia risks are not negated simply because this is a minimally invasive procedure. Sometimes the challenge becomes even more. What is more difficult is that you have fragmented perioperative information in care. That is, that the primary treating team is not the team that is performing the procedure. For instance, you could have a patient who is coming to you for a PTBD in interventional radiology suite. The primary team may be the surgical team, or it could be the medical gastroenterology team also that requires PTBD. And in that, you have a patient who doesn't recognize you, doesn't recognize the interventionist, and the primary team is not involved during the procedure. So getting any real information out of them, providing comprehensive care for them becomes challenging. A lot of these patients undergo repeated procedural exposure, particularly in radiotherapy. And that brings about their own risks. The access to the patient and to their airway is always restricted, which means there is a chance for delayed recognition of events such as hypoventilation or even airway compromise. So you're always on your toes. Most patients who require anesthesia in Nora, like as in your presence in Nora, are those adult patients who have anxiety or they have claustrophobia, or they're either adults who cannot cooperate or they're children, or they may be patients with chronic pain who are unable to lie still till this procedure happens. So each of these individual risk factors needs to be addressed every time this patient comes on table. And no matter what center you're in, even if we were in the best centers of the world. I can assure you that the recovery room mechanism for a NORA location is always less robust than what you have for your operating rooms. It is simply not feasible. These rooms bring about their own challenges. Then we come to the most important hazard, which is the radiation hazard in these rooms. When we think about CT or interventional radiology, we have to realize that they can use a high dose of ionizing radiation. Now, the radiation doesn't come directly from the only from the X-ray tube. There's a lot of leakage from the collimator's protective shielding, and there is scatter radiation from the patient themselves. Now, this risk of radiation is not just for us, right? It's for the procedurists and the anesthetists. Now, just look at the kind of radiation that is involved. If you were to go for a now interventional cerebral angiogram or a diagnostic cerebral angiogram also, they are the tiniest of the procedures that interventional neuroradiologists require your presence for. But even for them, the X-ray exposure can be as high as 250 chest X-rays for a diagnostic scan or 300 to 500 chest X-rays for an intervention, which essentially means that you are going to be exposed to radiation, which also means that there is a need to monitor this radiation and ensure we are safe. Now, how do we do that? We use protective gear such as lead aprons, thyroid collars, glass lead screens, and protective eyewear. This is where the problem starts, right? When we go in academic institutes such as ours, you go with, there's your resident who are all going in. And unless you truly recognize this risk of radiation, you will never ensure complete protection for yourself. So what you have to realize is that the NCRP actually has recommended dose limits for occupational exposure, where the maximum permissible dose per year is 50 millisievert. Now, how will I even know what dose I am receiving if I do not use a TLD badge? Now, the TLD badges are a unique problem in themselves because they are usually issued for the individual for a period of 6 months, and every 6 months they are read. But in most centers, TLD badges are not available to anesthetists. And you're not only receiving radiation in the CT scan, no, you're receiving it in IR. You're receiving it every time there is a C-arm brought into the OT for some X-ray. You're receiving it in the ICUs also when you're performing any procedures, which essentially means that TLD badges should be mandatory for all anesthetists who are exposed to radiation. Additionally, you have to remember that the dose of radiation decreases exponentially with the square of the distance from the source. Simply translated, the further you are away from the source of radiation, the safer you are. But your radiological suites may not really allow that distance. Now, there was this really interesting study done by Zerka et al., which sort of measured the radiation in the anesthesiologist versus that in the neuroanesthesiologist during both diagnostic and interventional procedures. Now, this was done in a good center, right? Because all anesthesiologists were behind leaded acrylic screens. They all wore lead aprons and they all wore thyroid shields. Now, this is not usual situation. Most often, we only get the lead apron. The interventional radiologists got the leaded glasses, they got the side guards, they had a lead apron, and they had a thyroid shield as well. Now, you look at the screen below you, you will see that for the anesthesiologist, when the angiography was done versus when an intervention was performed, 6 times as high exposure happened. For the radiologist, however, there was no significant difference in the two, which essentially meant that no matter what happened, the radiologist remained safe. When they tried to explore why this happened, it was simple. It was here. The answer was right there. During an interventional procedure, the anesthesiologists had 3 times as many interventions with the patient, which essentially meant that 3 times as many times the anesthesiologists went closer to the patients and hence closer to the source of radiation and got radiated. When you look at radiation in radiotherapy, you have to realize that this is a different ballgame altogether. Here, your lead aprons, your thyroid shields, your caps are not going to be effective at all. Here, we are dealing with focused, high intensity, short duration radiation, which is provided to the patient. These beams are highly controlled. So, as a result of it, there isn't any scatter radiation for us to worry about because the period is also short and these are controlled beams. But even if that were the case, your lead aprons and shields will be ineffective, which essentially means that during radiotherapy, we cannot be present during the active treatment and you have to be safe behind thick leaded walls. In short, for radiation during radiotherapy, you have to respect the closed door. In all centers where radiation happens, the protocol is that the door is closed only when the last individual has left the room, and there will always be signs that tell you that the beam is on or the X-ray is on so that you do not accidentally enter the room. Now, you have to remember before I move on to the non-OR preparation that the onus of saving yourself from the radiation is always going to be on you. There will always be too few lead aprons. There will always be too few thyroid shields, but your health and your safety is paramount. So making sure that you are adequately safeguarded through these procedures as you provide optimal care for the patients is your own responsibility as well. Now, when I put up this photograph, I had put it up just as, like a meme, but it's not far from reality. This is our own IR suite. And there we are. You cannot even see the anesthesia machine. It is behind that screen, somewhere where we are hiding and trying to provide care. So when we have to prepare this non-OR into an OR, we have to remember that there is very little space to move. And no matter how hard you try, your patient is too far away. Not only is the patient too far away, I don't really want to go too close to a patient when radiation is happening any which ways, which essentially means that I require longer extension tubings, whether it is anesthesia circuits, IV or art lines or monitor cables as well. The other thing to do is in an OT, if like there is extra loss or something like that, I can still take a call and say a little while later that maybe now we can put in an art line because this is unanticipated. In these settings, this becomes very difficult. So whether it is for vascular access or invasive BP, it is a better idea to preempt your need and get those access in before you even begin. Just like we tell our juniors every single time when we attach extensions, we need to be sure that these extensions are fixed properly so that you can be far away from the source of radiation and actually inject your drugs without getting exposed, without worrying whether the drug is leaking onto the drapes, and you can only find that out after the patient is bucked or at the end of the surgery. What monitors do we need? You need standard ASA monitoring. Whether the interventionist treats it like an OR or does not treat it like an OR, whether it looks like an OR or it does not look like an OR, the standards of monitoring do not change as per ASA and for us as well. Ergonomic placement is aspirational, honestly. Like, you can see over here in our OT itself, the machine is behind us. So if I were to come out of the OT for some time, I would not be able to see the anesthesia machine. But this is where slave monitors come in and they make our life so much easier. If you focus on the red arrow on the top right, you will see that we have a slave monitor there. It makes the interventionist life also easy. And if you were to step out for a minute, you would also be able to see the patient's hemodynamic parameters. For the airway, you need to ensure extensive airway evaluation. You need to have both standard and difficult airway equipment available in the same location, particularly because if you are in bigger centers, and radiologists, being radiologists, always get delegated to the basement and the dark, dank corners with no network where you cannot call for. So this evaluation becomes important in twofold. First, because you're not going to get any help. And second, because a lot of these procedures can technically be performed under MAC, but you may still need to convert to general anesthesia at some point of time. And if that happens, you need to be aware. You need to ensure an adequate availability of emergency drugs, oxygen backup, and suction. because your suction tubing is going to be in one place, you're going to be in the other, and emergency drugs are going to be under lock and key somewhere else. This will not work when the emergency happens because you're already too far away from the patient. So you've already maybe recognized the complications slightly later than you would have in the OT. So these sicker, frailer, older patients are going to give you a lot more grief and a lot less time to succeed. Additionally, you need to ensure that both the interventionist and the anesthetist are on the same page with regards to goals for anesthesia and plan for care. And your plan for need for escalated care. Are you going to require an ICU? Are you going to require added help? Need to be planned in advance so you can prepare. Safety equipment, including a crash cart and defibrillator, should be available and regularly checked. In interventional radiology, let's look at the 4Ps. First, the surgeries are either diagnostic or therapeutic and often urgent. Hemodynamic instability is likely because while they take their first punctures under ultrasound guidance, rest of the way they are blind with regards to their wires. The likelihood that something will bleed is there, and patients are also sicker. While there is a risk of bleed because a lot of times you're coiling your AVMs or aneurysms, there is also the anticoagulation which you have to take into account. They will anticoagulate to ensure that their apparatus is safe from the thrombus and does not lead to thrombogenesis. And this needs to be watched. There's also an increased incidence of contrast nephropathy or allergies. And these procedures tend to be prolonged even if your surgeon tells you this is a quick 30-minute procedure. Your priority is to be prepared for hemorrhage and embolization complications. So you need to know which procedures to watch out for where hemorrhage could occur and where emboli can be there. Also, you need to watch for the amount of flush and heparin that they use. You will have given only 1 pint through the surgery, but they will have continuously flushed through their catheters. So you need to ask them, particularly in small children or those with sick hearts, how much flush has gone in. And you need to keep a account of heparin being used so that the sheaths that they insert for doing the procedure can be removed safely only after the ACT has normalized. Usually, IR has non-OR staff who are unfamiliar with anesthesia emergencies, so it becomes difficult for them to understand your terminology and help you when the time is right. So it's a good idea to assign emergency roles beforehand. For our preparation, lead protection, obviously. You need to remember the risk of hypothermia from the long procedures. You need to keep in mind that extensions, tubing, circuits will be required. You do need remote monitoring visibility to make your life easier. And you need to be prepared for emergency conversion to GA if you have started the procedure under MAC. You're usually called to CT to do CT scans of uncooperative patients or to do CT guided biopsies. So these are trauma or emergency patients who may or may not be fasting. You're also required for pediatric sedations or GAs. Contrast reaction standbys are a likelihood here. You could have patients with unstable cervical spines. And a lot of times, particularly in our centers, patients come to us for CT-guided biopsies of deep visceral lesions, which means that they've come undiagnosed. You don't really have an idea of what's happening with them or how far things could go, which means that our priority, as always, would be the airway, which becomes a limitation. It becomes difficult because the scanner gantry becomes a limiting factor in itself. You need to monitor every time the contrast is injected for allergies. And also because CT scans are locations as such, we need to ensure a rapid turnover, but we cannot compromise safety. You have non-OR personnel as before, so you need to plan for emergencies in advance. And while it is not, it's not like with radiotherapy where you cannot stand inside, it is obviously advisable for us to limit our presence through the scan or to not be there when the scan is happening if it is feasible. You need to ensure lead protection for both the anesthesiologist and the patient. CT-guided radiation is hazardous for the patient as well. So for scans of the patient that do not require, where genitalia is not scanned, particularly for little ones, we do try and get genital screening. And you need to be aware that contrast allergies can happen. So emergency drugs have to be available. Extensions are, I think, routine in all of these procedures. Here, your remote monitors need to be visible to you at all times and be ready to convert to G. With pain procedures, remember the onus is absolutely on us, because here we are the interventionists ourselves. Most of these patients are already in pain. A lot of them already have chronic opioid use. A lot of our blocks require us to position them in prone, which may not exactly be comfortable for them. So this becomes a challenge because these NORA locations aren't equipped for positioning like our OTs are. So when radiologists plan these procedures, they will still do something and figure out positioning. Here, because we are the interventionists, we need to make sure that prone positioning is feasible. The patients may be in too much pain to actually allow the entire positioning. So those drawbacks and limitations need to be taken care of. You have a lot of elderly and frail patients. They require special care. And these patients may already be in pain. So this pain needs to be addressed before they are taken on table. Now, usually we give titrated sedation doses for these procedures and make sure these patients are awake. But because they are chronic opioid users, may already be in pain, this baseline requirement may be too high in itself. While you may aim to maintain spontaneous ventilation, please remember you may require airway rescue. For our pain procedures, you need to be vigilant about LAST and for neuraxial complications. Maintain clear communication with the patient throughout the procedure so that you can get an idea of their mentation. Now you have to remember that, we will say in an ideal world for ASA standards that you need one anesthetist monitoring the procedure. Here, no matter how many anesthetists you have, it is only natural that the person you have assigned to actually monitor the patient will also be preoccupied with the block. So even as the interventionist, you have to ensure that you're looking at the screen. It's important to protect yourself. And here, monitoring visibility takes on a new meaning altogether. Usually, our anesthesia monitors are placed on the anesthesia machine itself. So when you are the person performing the block, that monitor may not be visible to you. So you have to, unless you have a slave monitor, you have to ensure placement of the anesthesia machine in such a manner that this will be visible. You need to make sure that you have lipid emulsion available for last, and airway rescue equipment is available immediately. Most importantly, if escalation of the airway is required, it will happen in prone position. So you need to make sure that the person who is monitoring your patient has the expertise to do that. In radiation therapy, it's usually for pediatrics or proton therapy. It is usually that we are called for pediatric sedation. So this is done repeatedly. These patients already have oncology-associated airway or nutritional compromise. They basically just require immobilization, but IV access becomes difficult simply from the perspective that they are called multiple number of times. So in our institute, we usually secure an IV line on Monday and have the patients take care of it for the rest of the week. And we pull it out on Friday to minimize the number of IV lines required. Now, our priority is only immobilization and providing positioning in such a manner that radiation can be carried out. We definitely need reliable remote monitoring because you're too far away. You need safe sedation plans, you need safe recovery plans, and there is going to be a delay in discovering that a critical incident is happening and you being able to intervene because the beam doesn't get aborted. Until the beam is present, you are not in the gantry. You need to respect the closed door policy. You need to make sure you follow it. You need to make sure that the radiation alarms are working. You have remote monitoring. And in addition to remote monitoring, you also have video feed access of what is happening to the patient. You also need to be aware of emergency access protocol during radiation delivery. If that has to happen, how will you access it? Is something that you need to be aware of, even if that's not something you do. This is what the ORFIT looks like. ORFIT is the a commercial name for the device that is fixed onto the patient's head. Usually for the little ones, we get involved when they're unable to lie still. And this clearly looks very scary. Their heads will keep moving. And for the purpose of radiation, what happens is that the beam is trained to enter. They take a CT scan when the patient is asleep, and the beam is trained to enter and reach that specific location. So every single day, the patient needs to lie down in the exact same manner so that the beam knows where to reach. The second photograph is that of our proton gantry. If you can see the red arrow, that is where the patient is, and you can see how far away our anesthesia machine is, and the entire table rotates. Now you're about 200 meters away from them. So even if you look at the screen, if the picture on your right, the bottom screen is the video feed. So even if I can see that something is wrong with the child and I want to run inside, it's going to be some time before I can reach them once the beam has stopped functioning. Now, there are brachytherapy suites as well, but what you have to remember is that no actual radiation happens there. Only the beads and applicators are put in. Usually, it's done for cervix, prostate, and head neck. So, your concern, as always, is remote locations, untrained personnel. Positioning is a problem because, if you can see the picture on top, it's for the prostate. It's a really exaggerated lithotomy, so it becomes difficult for a lot of patients. And airway concerns for head neck patients when these beads are implanted, because a lot of times the radiation is done after surgery. So there's already a difficult airway that you're dealing with. And then the patient has to be extubated with these beads in situ. In MRI, you're in a different universe altogether. For adults, the MRI requires our presence when there are claustrophobic patients or patients who are too anxious to go undergo the MR. With pediatric patients, our presence is natural. You need to be aware about implanted devices and the fact that emergency access is going to be difficult during the scan. Not impossible. You can abort the scan and go inside, but it will be difficult because the patient will still be inside the gantry. They will still have to be pulled out and then you can intervene. These patients are prone to hypothermia. Your priorities are immobilization and positioning. Reliable remote monitoring is required because you'll be far away from the patient. You need to have safe sedation plans. And then again, there is the delay in discovery and intervention. MRI safety screening needs to happen for all personnel and patients who go inside for the ferromagnetic risks. And repeatedly staff training needs to go on for ferromagnetic risks. I'll just show you in the next slide. We need MRI compatible workstations and monitors. Emergency airway equipment needs to be present inside. If you have MRI safe laryngoscopes, that's brilliant. If not, then you need to figure out if you need to intervene on this airway, and tubing is your choice. How are you exactly going to evacuate this patient to zone 3 or zone 2 where your non-MRI safe laryngoscopes are kept and you can keep this done. Long extensions and tubings are mandatory. Backup MRI safe oxygen sources, that's aluminum cylinders, are important. You need to have remote monitoring. Make sure that the wires are not tangled and video feed access is available. It's important to look at equipment that you have and decide whether or not it's MRI safe, conditional, or unsafe, and only then let it enter the MR suite. The picture in the center is of the oxygen cylinder that has gone into the MR gantry. I wish this were anecdotal, and I wish we could say that this doesn't really happen, but it does, and the consequences could be disastrous. At the bottom left, you'll see a photograph of the ECG leads, which are usually used in MR, where we don't allow a tangle. The wires are as short as possible, and they need to be kept as straight as possible. But please remember, when the MRI sequence is going on, oftentimes you will face interference with your monitoring. So as a result, even your detection of the issue may be compromised. On the right, you have the MRI screening tools for the ferromagnetic substances. Till very recently, we also had the black colored wand that we used to use across the patients. But we realized that smaller ferrometallic objects such as coin purses, which a lot of our patients carried, the metallic pendants that a lot of children have around their necks or their waists would get missed, as a result of which we've installed these standing metal detection bars through which the patient has to walk around so that we can detect if there is any ferromagnetic substance in place. Now, this holds true for us also as personnel to make sure that we don't have keys, pens, wallets, phones that are walking in with us when we go. And every single time, it's important to reinforce this training. When we look at what interventionalists need from us and anesthetists, they need us to provide comfort and analgesia, immobilization, hemodynamic control, and most of all, early recovery. So then our anesthetic goals become the ability to restore a patient to preoperative status, simply because a lot of these patients are outpatient procedures, which means that they'll come in the morning, they'll leave in the evening, sometimes for long distance journeys, and we need to restore them as such. And they may be sick to begin with. Your pre-induction focused PAC is required with an additional emphasis on airway, positioning that your interventionist requires, and what limitations you have because of the patient's comorbidities and the patient presents because of fixed deformities or something like that. Whether or not there is any time for the comorbidities to be optimized, and if and how difficult is it going to make your life because the comorbidity is not optimized. Is this patient suitable for discharge? If not, you need to make arrangements for hospital admission soon. Vigilant monitoring is obviously vital, and detailed documentation. Just because it is an OPD procedure, the impact of the anesthesia does not lessen, which essentially means even if it is a simple diagnostic scans, our notes need to be detailed and they need to be perfect. And always have backup plans, particularly because you're alone. We usually tell our residents to be pessimists as anesthetists. Always assume that everything will fail and have your plan A, B, C, and D in place. When you need help, please ask for help before, not after. Now that we know that Nora has a potential to turn into a chaotic location when just the tiniest thing go wrong, what is our solution? It is streamlining. Why? Because we know that part of the chaos occurs because the environment is unfamiliar. And we have a very low margin of error because we are talking about patient safety. So what we can do is we can adopt practices from other high reliability organizations and make sure that our practices are safer. I'm just going to go over a couple of them. Similarity is clearly the key. If your equipment, drug storage, and processes are the same as you use in OR, your entire team is better aware. You can have additional standard drug protocols that everywhere you use the same sedation, whether it is in the OT, whether it is in IR, whether it is in proton, whether it is in brachy, whether it is in MRI, we will do the same thing. Then makes life easier. ID bands and checklists are mandatory. Now, we need to remember that a lot of these patients will undergo what is called a roadside or curbside consult, which means that they will walk in on the day of the procedure. They've never been seen by an anesthetist. But clearly, we need to see them, address them, and take them up for surgery, which means that not only is there a risk of slips and misses, there's also a likelihood that you will see the patient and then say, oh, shit, no, patient is not fit for surgery. For that, we need to have something like a triage, which the interventionists themselves do. They need to have a list of issues that they can screen at their level and say that this patient, even I understand, requires a fitness or a pre-operative evaluation done by the anesthetist. And then you can have another group of patients who don't require that and can be seen on the day of surgery, because clearly efficiency in NORA is the highlight of it, right? That it can be done on an APD basis, and patients can travel from far away and come for the procedure and get done on the very same day. Teamwork and cooperation is essential between the interventionist and the anesthesiologist. It is extremely important to have your regular practice drills, to have regular training programs for the entire staff that is posted there, because it's very easy to forget and the margin of error is so small that you are likely to have a mishap. Let me give you an example. Very recently, we had a short circuit in our MRI. We're attuned for disaster, and our fire team came in with the cylinders and fire extinguishers. It took a minute for the technician to be able to explain to them that they cannot run with the cylinders no matter what happens, which essentially means that unless you keep doing these repeated drills, out of spinal reactions, you could have another hazard in itself. We need to plan and schedule our cases to ensure that the sicker patients come on table first. You have a longer period to monitor them and whether or not they require indoor admission, because like I said, efficiency is important. And most importantly, you need to audit all of your practices to ensure that, if there is something that is repeatedly going wrong, we can take measures to correct it. The other solutions would obviously include keeping checklists and cognitive aids, because you're going to be by yourself with maybe 1 or 2 people in your team. So it's easy to have your brain frozen and to get frozen in times of a catastrophe. So having flashcards for emergencies, helpline numbers displayed easily, because call for help is something that people will understand in an OT. But in an environment where they're unfamiliar with anesthesia terminology, it may be easier to have a number displayed where I say, oh, this is where I call for help. Adoption of guidelines from RCOA, ASA are a good idea, but they need to be adapted to local needs as well. Incident reporting needs to be encouraged, because if you don't know what is going wrong, how will you correct it? Does this systematic evaluation and streamlining work? Yes, there is plenty of evidence that this is what makes the difference. That if your non-OR looks like your OR, if your non-OR behaves like your OR, if it's the same team, whether it is your nursing staff or your paramedical staff that is rotating in the OT and also rotating in your non-operating room locations, this is how you keep your patients safe. My take-home message is simple. If I want to have a safe NORA, I need to have a multidisciplinary approach with regards to planning and communication for all patients. There needs to be uniformity in design. There need to be set anesthesia protocols. And audits and reporting of incidents is what will make the difference and make NORA as safe as OR. Thank you.
Thank you, Gauri. Thank you for a discussion on the like this available suit MRI. So, is there any question?
No,
I
I
think there's
didn't see
no
any question
question
in the
You
chat.
can take them at the end, I suppose.
But
So,
still,
if anybody have any questions, please on the chat box. So, Gauri, I have a question to you. So, normally in CT scan or in the interventional radiology, what are the common complications you observe, or those can be there in the those
Sorry, your voice is breaking a little.
I think it's some issue. Yeah, Gauri, now is okay?
Yes, sir. Yes, sir. I can hear you.
So, the thing is that what are the I think there is other issue, na? So I'm just saying, what are the various common complications or adverse events that may happen in the CT scan or IR suit, as well as the MRI, and which you observed in the track or TMS?
So, for most important is the hypoxia or hypotension. So the problem is not the incidence itself; it is the time taken for detection. Because you are relying on slave monitoring.
I think there is some issue with the system now.
Sorry, the host has muted me. I'm sorry, I could not talk before. So hypoxia and hypotension are documented as the most common problems. But the problem, sir, is not in incidence itself. The incidence may be just as much as it is in the operating rooms. The problem is how soon we actually see it. Because we are relying on slave screens to actually tell us what is happening with the patient, already there is a delay in us figuring it out. Then this next delay is actually trying to get the procedure to stop so you can enter. Then with each location, it has its own issues. Like with the MR, like I said before, no matter how hard you try, no matter how expensive your equipment, there will be some amount of interference. So with the MR, you'll figure out only a little later.
So
With IR,
I'm asking, like, any some major adverse event or major complications did you observe in IR or MRI or CT scan?
so we had a bleeder not so recently. We had a bleeder secondary to an IR intervention. And what we saw was the hypotension. Now that's why I had highlighted that, because the vascular access is limited. It is a simple arterial or venous access that they have taken. So we don't see the loss happening. We're all trying to figure out what has caused the hypotension. It was a contrast blush that one of them gave a little later, which was much proximal to the lesion, which led us to realize that the bleed was happening inside the peritoneal cavity, which we would have otherwise not noticed because we were busy angioembolizing something far up ahead, and this is a major bleeder before. So because of that, we are always wary.
Yeah, so, and many a times, like when doing this IR procedures, like when they do this radiofrequency ablation of the chest or the liver, the many a times they there is some iatrogenic the pneumothorax and all these things. So those
Pneumothorax.
complications are, yeah. So this iatrogenic pneumothorax is very common, especially in this
So
RFA of the
iatrogenic
liver and
pneumothorax has become like it's like they don't even regard the problem with that is
recognize.
they don't even regard it as a
Right.
complication. Like
Yeah.
if you have a lesion sitting on
but-
top of
yeah, so,
the liver,
yeah, so it is
they'll
not.
say, okay, we are going to have.
Yeah, so it is not a grave complication for them, but for anesthetist and for someone is
It
new
becomes
in
difficult, yes.
that shoot, that maybe like he may be worried, he may be worried because it is, if you are doing like working in a very high volume center where you are seeing these things very commonly, then you are not really worried. But someone is just going to the IR first time and yesterday in the pneumothorax, then the condition may be different.
Yes. So if you have a lesion which is sitting on top of the superior surface of the liver, a lot of times they will induce the pneumothorax, the pneumoperitoneum to simply access that lesion and then do an RFA. So the challenge, like sir is saying, if you're doing it on a routine basis, that's why it's important to talk to your proceduralist to ask them how exactly are you going to do the procedure. So if I know that the pneumothorax is happening, I will watch for it. If not, maybe you're not trained enough to look at the images on your own and figure it out. So a lot of times, I'm sure people like so and so who was so senior have seen the pneumothorax in screen and said, "Listen, you're creating too much of a pneumothorax, and this needs to stop right now." But for someone who's a novice, maybe they will not even understand that this is a part of the procedure, or that this at beyond this point, I have to raise my alarm for threshold and say that this is a problem. Sir, you're muted. Sorry.
Yeah, so many times like maybe issue with the I think again there is some issue.
Yeah, regarding the patient concerns, I also want to add during my very early days, like 15 to 17 years back, when the MRI was just new. And since CT and MRI, they are like diagnostic procedures. So children coming for these diagnostic procedures, their parents are not willing to take the next date if they are having some conditions like URTI or LRTI. For them it's like a normal nominal सर्दी खांसी है and उसकी सर्दी खांसी चालू ही रहती है. So I want to share my experience that one kid was there. He was some 3.5 years old, and he got multiple time postponed because of his URTI. Then at last the mother was like कि इसकी सर्दी जाती नहीं है मैडम, आप कुछ भी करो, मैं सब लिख के देती हूँ, आप उसका MRI करा दो. And like I was also like junior and over enthusiastic, and I said okay, ठीक है, कर देते हैं. And that small overconfidence, you can say, has caused the life of that child. And that baby, he has gone into laryngospasm and he never come up desaturate. Okay, we intubated that baby, but then after almost 45 to 46 days, he was not able to survive. So that was a lesson for me कि simple सर्दी खांसी बहुत दिन से भी है तो भी I'm like it's not above your life. So many a time parents, they don't understand the importance of that airway, and I think that should be taken into consideration.
So we face this a lot for our radiation kids because we radiate them 5 days a week for 4 or 5 weeks. And most kids without cancer also have sardi khasi half the times. So our cancer kids always have sardi khasi. And then it becomes a challenge because every time you interrupt that radiation, you're genuinely delaying therapy. So what you're saying, there the parents don't understand, here the parents don't care. They look at you as the villain who is not letting the child receive therapy. So it becomes a very very difficult narrow path for us to choose that this cold today is okay, and beyond this I'm going to say I'm sorry, we cannot anesthetize you today. Ma'am, you're muted. Sorry.
Can I ask one question?
We have to draw the line, or we have to sometimes become so
Absolutely.
lenient with them also, and that is, I think, absolutely fair if we are in good faith we are doing that.
Yes, ma'am.
So,
Madam, can I ask one question?
yes, ma'am.
Yeah, I'm a surgeon.
Yes, ma'am.
I had one question. When the trauma patient is shifted to MRI, is it mandatory that anesthetist should be there all the time, especially in polytrauma patient? That is one thing. Then medico-legally, is it always needed that MRI should be having a MRI compatible workstations? That is second thing. And those MRI centers which are outside the hospitals, private centers, where such facilities are not available, what is a stand on such kind of things?
Ma'am, if you ask me, I'm an institutional practitioner. And we see too many bad things happen to patients even in the presence of MRI safe equipment. So if you ask me, should an MRI suite have MRI safe equipment? It absolutely should. Can centers function without them? Yes, they can, but patients should not be anesthetized there, because if something goes wrong, the court of law will obviously hold you accountable for having provided sedation in a place where you could not rescue them. Like, I'm lucky to have a center where MRI safe laryngoscopes are available. But even with that, I recognize the risk that if I have to intubate this patient when I did not plan for it, it weighs heavily on my conscience. I can only imagine how difficult it's going to be if I have to say, stop the scan, then I run inside, then we pull the patient out of the gantry, then put them on a trolley, bring them outside, and then I intubate because I don't even have an oxygen cylinder that's MRI safe. So it's a difficult choice to make, I understand. But I suppose that in the interest of safety, the push would be to have MRI safe equipment, yes.
So
I
right,
think
Gauri.
Nowadays,
is
I
that,
think most of the MRI suits.
I think so.
Sorry.
What I'm saying, most of the centers which are doing the MRI, which are not in the institute, most of them they are not like giving any anesthesia. They just do the MRI, plain MRI in the fully awake patients, mostly adult patients, and even if they do like MR for a pediatric patient, then they keep their parent inside so that the patient can, like child can lie down or sleep. So and but most of the things like the GA under MRI under GA is happening in the institute only, and I think the most of the institute they have this MRI step instruments nowadays.
I think most of the MRIs, they come with the MRI compatible anesthesia workstations.
Yes.
So I think equipments are available already. And regarding Madam's question of accompanying anesthetist for the every polytrauma patient, I think that is not necessary. For MRI, we need patient to be immobilized, and role of anesthetist come over there to keep the patient immobilized. If patient is like able to remain immobilized without anesthesia, so in that case, I think anesthesiologist requirement is not there, right, madam?
Yes, ma'am. Ma'am, I think the struggle with new MRI machines is only to get slave monitors. The MRI compatible devices will occur, but
You are muted.
which, sorry, I think the host is muted. So you need an additional slave monitor outside, which becomes challenging.
Yeah, that's true.
Can
So
I
I think
just can you hear me?
yeah.
Yes, madam.
Yes, ma'am.
Yes. So I'm not in the cancer patient, but I'm talking about the IR situations where many times being diagnostic procedures, they generally we try to do it with minimal sedation or TIVA in pediatric patients, and sometimes they just decide for the sclerotherapy and they say it will not take very long. But when you are doing in the oral cavity the sclerotherapy, post procedure, there is so much of congestion that the airway can get compromised. So those who are novices in the IR anesthesiologists, they may land up with sudden loss of airway or threat to the airway. So we should be even careful about that. That to start off, it's not so bad, the airway control, but after the procedures, it becomes worse. So that should be kept in mind. It was just sometimes we face this, so I thought we can just talk about it. Thank you.
Ma'am, I've been very fortunate to work with excellent interventional radiologists, and I've realized that, when working in these places, your best teacher is the interventional radiologist itself, and it helps to be chatty. It helps to ask questions about the procedure, what they expect after. And like you're saying with the sclerotherapy, like oral sclerotherapy, you should have bells ringing to begin with, that we are not doing this without control. We're not doing this without the patient being admitted, and this patient does not leave our site until everything is fine. And they're also very painful, whether it's an intraoral lesion or it is somewhere else. Sclerotherapy can be immensely painful for the patients. And you don't really realize, because it's like a tiny needle going in, and after the sclerosant is in, you have the patient that's howling and suddenly becoming uncooperative. And that's when they say, okay, now I need you to sedate. So I think, talking to an interventional radiologist really helps. And I've been lucky. We've had really amazing people teaching us. So it's nice to learn. But I think it's important to be chatty and ask them what you're going to do, how you're going to do it, and what do you expect will happen after. And they're more than happy to tell you most often.
Yeah. But sometimes when we are new, we do not anticipate. We thought, yeah, it will be done with. But we can really land up in problems. So I thought we can just discuss that. Yes. Very nice talk, Gauri.
Thank you.
That was quite elaborate.
Dr. Ashwin and Dr. Purnima, can you just log in with the only one device? This issue is happening from left, I think. If you are logging with the two devices.
No, we have only one device.
We have login with the
One device?
only.
Yeah,
Yes.
Two devices, it will provide echo.
there is echo, but we are from the one single laptop.
Okay, then should be okay. I think then there is somebody else who would do with the two devices. Gauri, your device is one, na?
Yes. From the laptop only we have logged in. Okay.
Okay, so I think we have discussion for almost 1 hour in on this topic. Dr. Purnima, over to you.
Yes. So that was quite an elaborate explanations for the problems associated with radiological suit that Dr. Gauri has explained us. And if anyone has some few more questions, we can take it at the end of the session. So thank you, Dr. Gauri, and thank you, Dr. Sohan. For the next talk, like apart from this radiological suits, there are like many areas of GI endoscopies, bronchoscopy, ECTs, managing patient in camps, casualties, or even in the wards, putting IV line or Riles tube, even lumbar punctures, where we are like anesthesiologists are called upon. Now, to discuss these areas, I would like Dr. Vaishali Mohad Madam to cover this area. And to chair this session, I request Dr. Ashwin Sonkamre sir. He is here with me. He is the GC member of our Maharashtra Society of Anesthesiologists, and he has a vast experience in giving anesthesia at a remote places. So I think he is quite proper person to chair this session. So over to Dr. Ashwin.
Good evening, everyone. I welcome all the participants who have joined. And regarding Vaishali, Dr. Vaishali, she is a cardiac anesthetist, a very senior person, and she was in charge of CVT-SOT at Sir JJ Group of Hospitals. She was a founding member of the Department of Emergency Medicine at JJ Hospital, and she took a lot of efforts to get the MD seats for the emergency medicine at JJ Hospital. Now she is working as professor and head at Government Medical College, Ambernath. So I request Dr. Vaishali to please take over and start her talk. Thank you.
Thank you, Dr. Ashwin. Am I audible?
Yes, ma'am.
Hello? Yeah, okay. And
Yes.
my presentation is visible?
No, madam,
no,
not
ma'am,
yet.
not yet.
Not yet. Is it visible now?
No, still
No, ma'am,
not.
not yet.
Yet.
We are only seeing
No?
those folders.
Selected it.
No?
No, we are only seeing those folders you mentioned earlier.
Is it visible now? No.
No,
Ma'am,
no,
the
madam.
folders are visible, not the
It
presentation.
has opened up actually.
I think you will have to click it.
You open this.
Now? No?
No,
No, not
it's like
yet.
you have just selected it. I think you will have to click it again.
I did it twice.
Twice.
We can't see your
Wait.
cursor.
Wait.
Okay, wait.
Okay, wait.
Now?
Now? No, everything is blank. Black. Now.
it will.
Just
Make it screen.
slideshow.
Yeah.
Slideshow.
Yeah.
Right.
Can you see now? Full screen?
Yes,
Yeah, we can see
Yes, ma'am.
now.
I'm not able to move my slides, but
Ma'am, could you send it to me? I can try sharing from my end. If you could email it to me, I can share it if you like.
I think you can just move from the from laptop, then just down button can move.
can you see now?
Yes.
Yes, ma'am. Yes.
But it is not moving. It's not moving.
Ma'am, in next to the slide show mode, there is something called a reading view. You could try with that. The reading view, which looks like a book, maybe that will work.
Can you see full screen now?
Yes, ma'am.
That reading view is not working. Okay.
Yes.
Yeah.
Now it is moving.
Yeah. Thank you. Thank you, Gauri. It was excellent presentation. My topic is related to means further extension from Gauri's topic. At the outset, I would like to thank ISA Mumbai Metro Branch and SAMS for giving me this opportunity. And special thanks to my colleague Purnima for giving me this lecture. Whatever most of the thing Gauri has already covered. Flow of this talk will be definition of NORA distinct. What is the difference between operation theatre and radiological NORA or non-radiological NORA? Importance in modern practice, why we are moving from invasive procedures to non-invasive procedures and requirement of anesthesia. What are the ASS standards given for non-operating radiologic room anesthesia? Individual consideration of NORA suites, preoperative, intraoperative, postoperative considerations, and safety considerations in non-operating room anesthesia, and the conclusion what we can learn from all these things. So the definition of NORA distinct, these are non-radiological, non-operating room procedures. They require, whichever procedure require anesthesiologist are collectively known as non-operating room anesthesia. Gauri has covered all the radiological things. I'm going to cover non-radiological things. Maybe there is some mix-up because I'm going to talk about the cath lab also. This primarily include gastroenterology, cardiology, pulmonology, obstetrics, psychiatry, some of the specialized procedures in case of pediatric and dental chair. I have not covered ICU procedures and whatever peripheral procedures Dr. Purnima was talking, because it was a each NORA distinct has it is such a in-depth topic. We can do one seminar for each one. So that is why I have taken some of them. Why we are more worried about these things is because, as Gauri said, unfamiliar environment, scarcity of ancillary staff or staff that may not be familiar with this anesthesia procedures. There is radiation exposure, and most of the patients are whatever we are getting are ASA class 1, physical class 3 and 4. So 1 and 2 procedures generally people do not ask us to come and give anesthesia. But some of the 3 and 4 ASA class 1 procedures patients, it is mandatory for us to be there. And as anesthetists are in less in number, so we means at JJ we have divided days for these procedures. So it is most of the time in larger institute, most of the time I think they have been given appointments and they will come and then we do such kind of procedures. So what is the difference between operating theatre and non-radiological, non-operating room anesthesia? So environment is spacious. There are standardized protocols in OT, while in NORA cases, it is variable and spaces are very cramped one, as she showed in her photographs. Monitoring is integrated with our machine, ventilators and monitors, they are integrated one. While here, monitor is different, defibrillator is different, syringe pump is somewhere else. So everything is portable. We are arranging and then doing the procedures. Proceduralist most of the time in ORs are surgeons. So surgeons are aware regarding the complications of anesthesia. They are used to help you out. They will tell you the things. But here in NORA cases, they are not from surgical background. They are from medical background. So GI, cardiology, psychiatry, they are not that aware about the operative concerns and anesthesia concerns. In OR, we are liberally using general anesthesia, regional anesthesia, then sedation, then various other regional blocks and all those things. But in case of Nora suites, it is difficult to give full-fledged general anesthesia, or you should have that facility to give it. So mostly the cases are done under sedation or monitored anesthesia care. So, which I'm going to talk, the various suites are endoscopy units, cath labs, ECT units, interventional pulmonology suites, where bronchoscopy, stenting, biopsies are done, IVF labs, where oocyte retrievals are done, dental chair. So these are the 5-6A I'm going to talk in depth. Rest of the things I have not included. Secondly, I have not mentioned all the doses of drugs and each and every equipment required for that particular suites. So I will cover it in the last 4-5 slides. So what are the clinical implications? So there is a growing demand for these procedures. Why? Because they are more non-invasive, minimally invasive procedures. They are safer. They can be diagnostic and as well as therapeutic. It requires less time. Most of the time, they are daycare procedures, and technology is advancing so fast. So imaging is coming, and with a smaller, the diameters are going down, scopes diameters are going down, and nice amount of AI imaging is coming. So that is why it is possible to go with the use of technology, endoscopists or GI endoscopics or bronchoscopists, they can go faster and they are advancing faster. For the same time, at the same time, we are also advancing in our monitoring techniques. But we need more standardized protocols and guidelines and tailored anesthesia strategies, which are same and which are percolated to our juniors whenever they are going to give anesthesia during in these suites. So emphasis should be on the patient safety and interdisciplinary teamwork. The thing is, patients are coming from far away and they are coming for daycare procedures. So if we are not telling them that they should come in an NBM status, after coming here, keeping them NBM will definitely lose 6 hours time. So this interdisciplinary communication should be good among anesthetist and proceduralist and their residents. So someone else is seeing the patient, he is sending you for PSC on day 1, then after 3 days the date is given, and then that patient is coming, everybody has forgotten about the appointments given. So this should not happen. There should be a good communication between the years. So the team should be divided accordingly. This has been done and the days should be divided. So that those days are made fixed, and on that those dates, they should be called for the procedure in elective cases. But in case of emergency, anyway, we have to give anesthesia whatever way the patients are presenting to us. So we are using anesthesia in operating room in a standardized way of ASA standards. The ASA says that we should use the same standards to the NORA also. Because the risk is not less and the procedure is minimally invasive for surgeon, but not for the anesthetist. Anesthesia is never minimally invasive. So we should maintain our standards. So all the NORA places should have a reliable oxygen source, reliable source of suction. There should be sufficient electrical outlets for any type of anesthesia equipments. If anesthesia workstation is there, monitor is there, syringe pump is there, video laryngoscopes, defibrillator, everything requires electrical supply, and that should be available during that procedure. Basic resuscitative equipment should be available, as well as, if required, difficult airway management card should be available, or it should be available nearest one place. In a tertiary care institute, these departments are far away from each other and they are far away from the main OT complex. So in that case, either you should have a designated team and a backup team which will be ready for any kind of disaster. Adequate illumination for the patient, anesthesia workstation, and other monitoring equipments. Then sufficient space should be there to accommodate the necessary equipment and personals. So each procedure room must have adequate anesthesia drugs, intravenous IV fluids, other supplies, monitoring equipments, including capnography and defibrillate. Adequate number of trained staff should be available to safely transport that patient out of NORA and to a post-anesthesia care unit. Otherwise, one mama, one maushi, there is no one to lift the patient, to keep the patient. So these things should not happen. Anesthetizing location, it should be determined by the healthcare facility to be the wet locations where there are a lot of fluid. Even cath labs have a lot of fluid, birthing rooms, arthroscopy, cystoscopy. So there can be a fire hazard, there can be electrical EA. So these wet locations should be marked. And there should be a well-equipped recovery area or high dependency unit just beside or outside the NORA. So, suites. And fire safety and fire evacuation plans should be in place, and a repeated mock drill should be done. So now I will consider NORA districts. So first I will talk about the cath lab procedures. So why the cath lab procedures are difficult? Because everybody knows that there are unique challenges. Cath lab has a image intensifier or C-arm which rotates. Their table also goes forward and backward. Our machines are far away from the patient because image intensifier takes half of the room. The rooms are crumbled. The gantries are away from the monitoring rooms, and only two anesthetists can be inside, or you have to sit in the console. So, and 2-3 cardiologists can be inside. But the patients coming for cath lab procedures, they are very challenging. So most of the patients are ASA 3 and 4. Adult patient, they are geriatric patients and pediatric patients. They are having some kind of cardiac problem. So patient's preoperative assessment of cardiac reserve is very important. In pediatric patients, those who are coming for device closure such as ASD, VSD device or PDA closures, they are having associated respiratory problems. As we spoke regarding the upper or lower respiratory infections, how challenging they are. And adult patients, they are on various types of drugs, medications. So ischemic heart disease, they are on beta blockers, calcium channel blockers, ARBs, ACBs, blood thinners, and so on and so forth. So this patient, they should be evaluated preoperatively for cardiac reserve. So you are there in the cath lab only. So most of the time, these patients are along with the 2D echo reports or TE reports or something like that. But if these patients are more complicated due to LV failure, so they might be on the ventilators. In those cases, the challenges are different. So airway and positioning, we should assess them for difficult airway predictors, and considering that the cath lab table is narrow, we should plan our intubation. Even if the patient doesn't require, it is okay. Even if you are doing cases on LMA, it's okay. Your plan for intubation should be ready. So access to that patient for the emergency intubation is very difficult due to C-arm positioning and a narrow cath lab table. So it is, you should know where are the pillows kept, where are the laryngoscopes are, where are the video laryngoscopes available, is there adequate blade available or not, or something. Everything should be checked pre-operatively or pre-procedurally, and you should be ready for the patients. Sometimes I have observed the bariatric patients, we are not able to keep put them on the cath lab tables. So we need to give so many attachments to keep them on the cath lab tables. In such cases, difficult airway should be tackled in the first position. Then and then only we should allow the cath lab cardiologist to go ahead with the Then equipment disconnections are very common because the IV lines are far away from you, as Gauri said, and monitor cables are dangling. They should not be dangling. So you should keep all your monitor cables, IV extension lines secured well. Accidental disconnections, they are major risk when the C-arm is rotating. Then radiation safety, I will skip this. It is already covered. Anesthesia techniques, which are the anesthesia we can use? So procedural sedation versus general anesthesia. Simple diagnostic procedure or stentings, that is PTCA, it can be done under monitored anesthesia care. And prolonged or complex interventions such as TAVR, TAVI, or mitral clip or ventricular tachycardia ablations, they require general anesthesia. So general anesthesia, whenever we are planning, we should be very thorough of the patient's pre-operative medications. What medications these patients are taking and what interactions our general anesthesia drugs will do with those medications. So we should evaluate that patient accordingly. Electrophysiological cases for procedures for mapping or provoking anesthesia, these patients are mostly on antiarrhythmics or beta blockers, and volatile anesthetic agents should be avoided because they will suppress these arrhythmias. Instead, using of total intravenous anesthesia with propofol or ramifentanil is better. Pacemaker insertion can be done under local anesthesia and sedation. And endotracheal intubation or LME is preferred for prolonged procedures. Nowadays the gastro LME is also available, through which the TE probe can go along with our secured airway management. So various other types, you need to manage the tubes well, endotracheal tubes, because if the patient, if the cardiologist is using transesophageal echocardiography, then you have to put a little smaller tube, but then you should be careful that patient should be thoroughly investigated before that he is in NBM, and antiemetics should be administered. So hemodynamic monitoring in cath labs, vascular access, generally arterial lines are in place and taken by cardiologist. So it is easy to monitor bit blood pressure, but it doesn't mean that you should not tie your NIBP. You should have. Then it is important to take one arterial connection to your ear, so that you can draw the ABGs, you can send the samples for ABG analysis as well as ACT monitoring. Heparinization should be properly done in all the cath lab procedures. Agent selection, cardiovascular stability, most of the agents are used, are etomidatis preferred, and be ready to treat sudden bradycardias and hypotensions. Your inotropic agent should be ready, your vasopressor should be ready, and you should monitor patient with standard ASA monitoring as well as along with the IBP and ACT, ABG, etc. So this was regarding the cath lab. Now we'll come to the reproductive endocrinology, that is IVF labs. So anesthesia in reproductive endocrinology is tailored for brief outpatient procedures. Generally, oocyte retrieval is the primary goal, procedure done, and the goal is, our anesthesia goal should be patient comfort, absolute immobility during the follicular, during the oocyte retrieval for precise follicular puncture, and rapid recovery with zero detrimental effect on oocyte quality or embryonic development due to our anesthesia medications. So these IVF labs and their clinics, the minimum requirements are, there should be minimum fetal or embryonic toxicity, because the drugs can cross over into the follicular fluid with the shortest duration of action. And these procedures are generally over within 20 to 30 minutes, and recovery should be managed within 30 to 60 minutes, allowing patient to be discharged safely to their homes on the same day. And sometimes these patients are coming repeatedly. So due to IVF failure, these patients are coming repeatedly. So procedure related anxiety, if the patient feel pain or something like that, before every time patient is coming, the patient will feel anxious. So preoperative counseling by the anesthesia team is very important to address emotional distress and ensure a smooth clinical workflow. Now the medication profiles, propofol is a gold standard for indication and maintenance. Propofol for oocyte retrieval does not adversely affect fertilization rate, embryo quality, or pregnancy outcomes. Fentanyl, ramifentanil, and midazolam, they are frequently used to manage procedural pain. Fentanyl and ramifentanil has a minimal penetration into follicular fluid, making it exceptionally safe for IVF. And NSAIDs are generally restricted if immediate embryo transfer is planned. Now the TCI pumps are available. We can very well titrate the things. So ramifentanil is emerging as a good sedative agent, agent for the short procedures. Coming to interventional pulmonology suites, an interventional pulmonology suite is a specialized minimally invasive hospital unit which is dedicated to diagnosing and treating complex airway, lung, and pleural diseases. So most of the procedures such as rigid or flexible bronchoscopy, these procedures are done to take the biopsy or place the stent. They require airway control by the anesthetist as the procedure. It shares airway with the breathing tubes, with the endotracheal tube. Secondly, endotracheal ultrasounds are done because they give a good mm, inside depth to the endotracheal bronchoscope is attached to the ultrasound is attached to the bronchoscope, flexible bronchoscope. So it can go inside and do the ultrasound and can give images which require standstill patients. So it requires deep sedation also. Airway stenting or dilatation and pleural procedures such as thoracentesis, chest tube or pleurodesis. So these are the interventional pulmonary suites where procedure person, and you can see the anesthetist is standing behind and is having a bag in his hand, and there is no space for him to move, and he's sharing airway with the patient, with the pulmonologist. So core anesthetic techniques, total intravenous anesthesia is generally used and it is gold standard. Various drugs, propofol and remifentanil allows rapid emergence and predictable recovery. While general anesthesia is used with airway control for complex IP procedures to guarantee the patient's immobility and standstill airway also. And controlled ventilation will give some amount of liberty to hold the ventilation when the patient, when the pulmonologist is doing his procedure. So deep rigid bronchoscopy, it requires deep general anesthesia and full muscle relaxation because the metal bronchoscope, it itself acts as a airway, and anesthesiologist has to ventilate through the side port. Various supraglottic airways are used for doing this flexible or robotic bronchoscopes. Since airway is in your hand and the bronchoscope goes inside through the LMA, they provide a stable airway for the pulmonologist. Various ventilation strategies, all of us knows we are using since long time when the pulmonologist is doing his procedure inside the trachea or inside the bronchus. Sometimes we are giving apneic oxygenation or low tidal volume ventilation and high PEEP, which is important during advanced procedure or robotic bronchoscopy or lung ablations to prevent the atelectasis and maintain patency of the distal airways. Airway pressures must be carefully monitored to avoid barotrauma, particularly in cases of severe COPD patient or bullous lung disease. Jet ventilation is one of the strategy during rigid bronchoscopy where conventional ventilation is difficult. So clinical challenges during various pulmonology interventions are, we are sharing airway with them. If the laser is used, we should be very careful regarding the FiO2, which is typically reduced up to 40%. And dynamic airway obstruction possible in cases of large central lung masses, which we can completely lose airway when the muscle relaxants are given. So we should be very careful if there is a dynamic airway obstruction. And while emerging from anesthesia, a patient should not cough, which can lead to the bleeding or displacement of surgical instruments. So deep extubation strategies should be adopted. And in this case, LMAs are very useful. Coming to the endoscopy suites. Endoscopy suites where we are doing ERCPs, then various other procedures such as endoscopic ultrasound, then ogidoscopies. These are the various scopies that I will highlight: endoscopic retrograde cholangiography and endoscopic ultrasound. Because here sometimes we require full general anesthesia to keep your patient stand still. So it is a specialized endoscopic procedure primarily used to investigate and treat the biliary system and pancreas, such as gallstones, biliary strictures, pancreatic disorders, various tumors, and it is nowadays very popular with GI endoscopist. So most of the things are tackled with ERCP. And with the development of better scopes and better monitoring system, most of the pancreatic duct cyst, pancreatic stones, gallstones, various tumors, they are dealing with ERCP. Then endoscopic ultrasound, it takes endoscope deeper to the level. Literally, it goes inside where your endoscope cannot reach. It combines endoscopic ultrasound technology to provide detailed images of gastrointestinal adjacent structures, such as they can do the tumor staging, submucosal lesions, evaluate pancreatic masses and cyst. They can take the biopsies, guided sampling for accurate diagnosis. So these endoscopic suites are advancing like nothing. We are moving from more and more invasive procedure to very less invasive one, and we should that is how we should advance our anesthesia techniques also. So key consideration: managing the patient's airway. We are sharing, endoscope is going down, and our tube, the size of the tube and endoscope. The endoscope is a thick one, and the way of insertion of endoscope along with the tube, if required for major procedures such as in the robotic sleeves and all those things, then we have to consider our different way of anesthetizing the patient. Managing this patient's airway, sharing of airway, and restricted airway. So these three things we need to take into consideration, and we should talk to our endoscopist because before the procedure we should address their concerns, and we should design our anesthesia accordingly. Addressing unique procedural positions, these are done either in the prone position or in a semi-prone position. In those cases, maintenance of oxygenation is very important, and how we are going to do that, it should be our priority. Patient should be should have an NBM status. These patients are on anti-obesity drugs. So they may not be fully NBM if they are on anti-obesity drugs. So we need to take into considerations those things also. Mitigating risks like hypoxia and pulmonary aspiration is in an environment for standard operating procedures should be in place so that these things can be avoided. Mainly the sedation or monitor anesthesia care or general anesthesia with propofol is preferred. Problems of bariatric patients, their comorbidities and medication I have already told, and post-operative nausea, vomiting should be taken care of. Urological endoscopies, it is used for to diagnose and treat conditions like conditions in the kidney, ureter, bladder, and urinary tract. The core considerations are patient domain. Mostly patients are elderly with various cardiovascular, pulmonary, and renal diseases. And procedure durations, office procedures like takes minute, while the complex procedures last for hours. And surgical reflexes such as bladder distension or scope manipulation can trigger the autonomic reflexes. And lithotomy position, which has got its own problem. Anesthesia in dental chair, again airway shared. Aspiration risks, the presence of blood or debris in the oral cavity, and various patients positioning problems for complex cases involving children or patient with special needs. So airway protection is important, and nasogastric tube or reinforced oral endotracheal tube is often preferred to keep the surgical field clear. Throat packs, surgeon should put the throat pack to prevent the debris going in. And allergic reactions to LA are very important consideration in case of dental chair. So, position in the dental chair, supine or semi-supine. Patients are usually positioned flat or semi-upright position, which shifts the diaphragm and cause compromise in pulmonary function. Emergency access, the dental chair must be fully adjustable. There should be a manual release or a quick tilt mechanism to place the patient in a Trendelenburg position immediately to manage airway emergencies. So this is regarding dental chair. Now coming to the anesthesia for ECT, electroconvulsive therapy, it is a treatment option for patients with pharmacotherapy, resistant depression, catatonia, bipolar disorder, and other psychiatric diseases. The ideal anesthetic agent which provide amnesia with minimal effects on hemodynamic stability and seizure duration should be used. You should follow the procedure. Typically, the PSC should be done, patient should be NBM, consent should be taken, IV line should be secured, 100% oxygen should be given, and induction agents of your choice, which will affect less on the electroconvulsive therapy should be used. Succinylcholine is the preferred muscle relaxant for ECT. There should be a soft bite block should be kept, and in a post-procedural aid, the patient should be shifted to the recovery room. All ARSA standard monitors should be used for monitoring. We have seen the particular NURA places or units where we have seen various types of procedures. Now, commonly I have done pre-operative, intraoperative, post-operative considerations I have taken into, which I will tell now. For all the procedures, they are common. So, pre-operative evaluation must be done for all the patients. Pre-operative optimization of various types of comorbidities should be done, at least for the elective cases. For emergency, anyway, maximum optimized patient we should take. Patient should be in kneel by mouth. Patient should give you informed consent. Always check. whether patient has given consent or not, or the patient is inside the endoscopy room and consent is not signed, and the surgeon is taking his consent on the table. I have seen this. So this should not happen. An integrated approach allows for the risk stratification, risk reduction, optimization prior to the day of procedure, and can easily be applied to all the patients coming to the procedure in hospital, whether they are coming from far away, daycare, for a daycare, or for whether they are admitted in hospital procedures. Anesthesia technique, mostly sedation, will use the midazolam, propofol, dexmedetomidine, and remifentanil. Most of these drugs are short acting. They do not have a longer period of action. These are used. General anesthesia is preferred for complex procedures and high-risk procedures. Monitored anesthesia care, wherever applicable, is used. Regional anesthesia, spinal, epidural, combined spinal epidural, nerve blocks, these are used regularly for the procedures. Checking of anesthesia equipments before starting the procedure, drug vial icons, labeled syringes, sedation depth scale, warming fluids, warming blanket, emergency drugs should be available before starting the procedure. And monitoring equipment checklist should be checked. Everything should be in proper working year, because most of the time defibrillators doesn't work, monitors doesn't, they give up in between, NIBP curve doesn't work. So these things are happening. So that is why before starting any case, we should check all the monitors. Intraoperatively, qualitative clinical signs should not be ignored. Whether the chest excursion or whether you have a long stethoscope, just put it inside and on the chest of a pediatric patient, and that is a good monitor. Though even if your monitors give away, such as a pulse oximeter is not working because of the cold environment, or you are not able to palpate the pulse, you are not able to auscultate the patient in between, or your pulse oximeter is not working, or your patient is cold one. Simple, these two things are very important. You can see the chest excursion, and if provided, you should be nearer to the patient, or at least observe those things. If the patient is under heavy drips, it is not possible. Arterial lines, wherever available, cath labs, arterial lines are available. Always monitor the BP through arterial line or the pleth, arterial plethysmogram. Temperature monitoring, it must be used. It must be used everywhere, specifically in cath lab procedures where pediatric cath labs you are doing, you must monitor the temperature. Your patient may not come out of anesthesia just because of hypothermia. ABG, ACT, wherever available, should be monitored. Perioperative pain management, various ways are used for management of perioperative pain. Since we are advancing in the pain management, various regional blocks, epidural analgesia, PCA pumps, where there is pharmacotherapy, traditionally we are managing pain, but intervention techniques should be used wherever possible. You can add along with the opioids. If the daycare procedure is there, we cannot give much opioid, then add acetaminophen, gabapentin, NSAIDs, combination of ketamine and dexmedetomidine, whatever is possible in a combination way, perioperative pain should be managed. Postoperatively, discharge planning, postoperative planning and discharge planning. It should happen in a 2 phase. Ideally, in all the patients of NORA, we should monitor patients' vitals according to modified Aldred scoring system. One thing I forgot to tell you, whenever you are giving a monitored anesthesia care or sedation, whatever, you should always monitor the sedation level, depth of sedation. It is mandatory. Ideally, this phases of depth of sedation should be pasted on those NORA rooms wherever you are working. You may not, you might not be able to recall the things, or your juniors are not able to do this. So pasting those things on the walls of the A is very important, just to find out where my patient is in adequate level of depth of anesthesia or sedation. So these two, Ramsey sedation score or whatever, modified IDED scorings for discharge criteria, taking out your patient from the NORA room outside to the recovery room. So high quality standards as those in ambulatory surgery settings can help to overcome the adverse outcomes and ensure a safe discharge plan for each patient. For phase 1, we should focus that patient should be fully recovered from anesthesia. Then and then only you will take out that patient from the room to the recovery room and return the signs to nearby baseline for the phase 2 project. So phase 2 focuses on the preparing the patient or their families or caretakers for the discharge to the home or an extended care environment. So here the role of anesthetist is he has to tell the post-operative NBM period, post-operative analgesia, whatever medications he has given, and he should write all those notes in the on the paper, and the clear notes should be entered while discharging patient from the recovery room. So post-operative instructions should be written by cardiologist and anesthesiologist clearly, and further appointment should be given by cardiologist if he wants to see the patient again in a daycare procedure. In admitted patients or IPD patients, the clear instruction should be written on the IPD notebooks. So whenever we are talking about NORA, even Gauri talked about the safety and quality maintenance of the NORA. Here, patient safety practices such as we are doing, whether right knee replacement has to be done or left knee replacement has to be done, we are checking those inside the OT. Here also, it is very important to check the patient's identification, procedure, relevant and other relevant things, which type of what patients, patients having the same name posted for PTCA but having another here has been exchanged in front of my eyes. So please be careful about the patient identification. ASA basic standards for pre-anesthesia care should be followed. The lead anesthesiologist for each area should involve writing protocols or standard operating procedure to particularly to that NORA suites. Pulmonary, if you are working in a pulmonary unit, we must write those standard operating procedures. We should be involved, or a pulmonologist or a team should be involved whenever we are preparing those SOPs. The process of activating a code, who will activate, who will respond, it should be who will be your backup anesthesiologist, which intensive care will take your patient, which emergency department will help you. All these locations should be designated thoroughly before starting any patient in the NORA. Procedure specific simulations, they are strongly recommended to identify and logistics before an actual emergency arises. It is very important. We should do the mock drills. We should simulate the patients. We should learn from the simulations, and we should go. Every time the teams are changing, every 3 monthly, our residents are rotating. Every time the teams are changing, first 7 days they are chaotic because they are not aware about the new places. So it is very important to do the mock drills. After all these things, I would like to confirm NORA is an expanding thing beyond OR. Non-radiological settings pose unique challenges. Safety depends on preparation, monitoring, and collaboration with all the involving participants. Team training and simulation drills are important. Checklist graphics or crash card icons, they should be displayed everywhere, and anesthesiologists should be involved in drafting the standard operating protocols for all the suites. Thank you.
Thank you, Vaishali. It was a nice talk with a lot of information regarding the non-radiological NORA procedures and the involvement of the anesthetist. To add to this, I would like to tell some of my experiences since I have worked in remote places in rural Maharashtra. And I would like to say that the training of the qualified and unqualified, both the staff is very important, which has helped me in the locations in the rural Maharashtra, remote locations in the rural Maharashtra. I'll give you one or two examples. We were operating for cataract in a place called Jamner, where a lady was given a block and then she suddenly landed up into bradycardia and aphasia, and we could not detect. This was in way back in 2016. So we went through the literature and found that the brainstem was involved because of the block given retrobulbar block. So we had no option at a remote place like that, but somehow we managed, the unqualified staff managed to go get intralipid from Jalgaon, and then we could salvage the patient after 2 hours of just monitoring without doing anything, just providing some oxygen and all these things, the supportive therapy. So this is one of the case, and another case is uh, in the CT scan where a patient went into a cardiac arrest. So the radiologist, we had taken some lectures of CPR and all these things for the trained and qualified and unqualified staff. So the radiologist came to our help, and he gave the CPR, and we could just intubate and then do all the other procedures, access, give the drugs and all. Then we could save the patient. So training of other people other than the anesthetist, as Gauri said, these are, and both of you said that these are not the routine people we work with, like the surgeons who know the scenarios when things can go wrong. So here, these people usually don't know, and they will say most of the times as a joke, we hear from them, I call the doctor from the radiologist or the ophthalmologist. So they just forget that even they are doctors. So training of CPR and all these things for the MBBS and qualified and unqualified staff is also important, because in one of the arrest in cataract patients, the mama came running and he just lifted up the legs of the patient because he was knowing the things beforehand. So it is one simple step, but then we could save the patient. Coming to one of the things, we narco analysis is also involved in the non-radiological NORA. So we do it at one of the nearest hospitals here, in which the anesthetist plays an important role. So narco analysis is not very frequent thing, but the residents and all, they should be taken along with you so that they know what narco and how thiopentone is used to get the test done. So, and one more thing is, now there is a lot of fad of doing tattoo and all these things on the body. So we have to be very careful in MRI, because the tattoo ink contains iron oxide and it can cause severe burns in the places where the tattoo is being done. So the company usually provides some ice packs which are MRI safe. We can cover those parts where the tattoo has been uh, imprinted on the body and then carry out the MRI. So this is some of the comments from my side. You can also share some of your experiences since you have also done camps.
I want to I want to make a comment. So like sometime in the our medical GI suits, like this endoscopy suits, many times then this media people, they want to do a cholangiogram, especially like patient with the cholangitis and all these things. So they do a cholangiogram. So normally they do with the iodine based dyes, but sometimes if the patient is like sensitive or like allergic to the iodine based dye, that time they do a air cholangiogram, or they put around either air or CO2. So like one of the incidents I can tell you, so that so while putting that CO2 into the bile duct, they accidentally put that 100 ml of the CO2 into the portal vein. So then there is a big CO2 embolism and all these things. So we have to be careful, especially when we are doing all these procedures into the things.
It is advisable to use CO2 in such cases.
Yeah.
They should always use CO2 only.
So,
But the
so
things
even
are like not everywhere. See, we are working in a tertiary care institute, so it is possible. But outside, it is not possible. Where there are single endoscopic suites or where there are respiratory, interventional respiratory suites, nothing is there. So, visiting an anesthetist, he has to demand, is what I feel, that he has to demand basic resuscitative equipments, basic drugs, basic anesthesia workstation should be there. So, and defibrillator, it should be there. It is must. And the staff should be trained by repeated training or repeated because their staff goes on changing also. Some of the nurses are changing, some of the class 4s are changing. So individual suites, those who are running, it is very dangerous. At least in tertiary care hospitals, at least our colleagues are there or someone, those mamas are, they are working since long time, so they know so many things. Or they know the place where someone has to be called or some things has to be shifted or something like that. But whenever we are going somewhere in a newer place, it is very difficult to do all these things because you have a limited access for everything, right? From the personals, ancillary staff, drugs, and equipments. Everything is less. So the newer generation, those who are working in this particular setups, they should be very careful because at the end, it is the anesthetist who does something wrong and not the endoscopist.
yes, correct. So that's why so when we are dealing with all these various non-operating room scenarios, we have to be very careful, and especially we need to train our associates and auxiliary staffs and all this because ultimately it is your responsibility to safeguard the patient. So, and actually, we also have to do be aware about the condition, the situation, the instruments, everything, because whatever is there in the OT, you may not find there in the NORA setting. So, it's always good to be aware and about the environment awareness is required.
And these procedures are going to increase definitely, and our challenges will definitely increase. With the development of technology and AI, everything will increase. They will
Anesthetists
require
are
more
now,
and more. They are required
everywhere
more
they
and
want
more.
anesthesia.
Yes, madam. It is
So,
estimated that in next
yeah.
10 years, volume of NORA will
So
be
nowadays, like we have this interventional pulmonology. So nowadays they do this EBUS and all these things, so that these respiratory medicine people, they want to do the this endobronchial ultrasound, and so they also want the one patient to under GA. So the interventional pulmonology is also going to in a big way. In our
Yes.
hospital, at least 4 days in a week they want GA for the patient.
And where they want GA, there is nothing. There is, and you are sharing airway with them, and they want your tube should be smaller than their ear. So the means never know inside what they will do. If the patient will start
So what
bleeding
we
now
do,
from a bigger tumor.
So what we do, we put the LMA and then through them they do their procedure.
And what about if the something goes wrong and patient starts bleeding inside?
Oh, so normally they just do this
Yeah.
finding.
But nowadays these procedures are increasing, definitely. Definitely they are increasing. Yeah. And now most our respiratory medicine is far away from the major building or major OT complex. They want to do a smaller foreign body in a remote bronchus there, a child
No,
of 10-year-old.
we
So
always call them in the OT. So we have that minor OT complex. So we don't give in their ward. we give anesthesia in
Yes,
a minority complex. They come there, they do their procedure, and then they go.
yes. So we also say the same thing. You bring your patient to OT, do the procedure, and then go away. So this is the means we need that OT environment for the safety of the patient.
Yes, that is true, madam. And now there are published data that is saying that in next 10 years, volume of NORA will be taking over the operating room anesthesia. So we
Yes,
have to
yes,
be prepared for that.
Exactly, because
yeah,
everything right from the cath lab, they have taken over almost more than half of the cardiac surgeries.
yes,
Yes,
So the
yes,
cardiac surgery is going down in a big way, and everything is
yes,
done
yes.
by the cath lab and in this interventional cardiology way. Same will be
Even,
happening into the so nowadays. This endoscopy suits, they even are like removing small this colon tumors and the rectal tumors by the this endoscopy.
yeah, and the secondly, bariatric surgery, endoscopic bariatric will increase now.
Yes, yes.
The people, those who are undergone invasive bariatric, in the next sitting, they are going on a minimally invasive endoscopic bariatric. So robotic bariatric is coming very fast. And that way, again, that will be a bigger issue for us. So endoscopic sleeve gastrectomy. So the people are ready to do endoscopically. So those cases, we will require our preparedness more for giving anesthesia, because the bariatric itself, it is very difficult. It itself has its own challenges, and then endoscopy over it will be a difficult task for us.
Okay, I think now we have exceeded the time of 7 to 9. We are then a good discussion on this. So, and
I
if
think I will
any
sum
more
up.
questions,
Yes.
I just want to invite all of you to the next month, 28th June, for our research methodology workshop in Tata. That is a full day workshop in person, and it is only nominal of 800 rupees registration. You can anybody interested in like how to do research, how you frame the questions, how you what method you choose to do research, and various different part of the research, they can come and do the workshop. So now that Dr. Purnima, over to you.
Yeah, thank you, thank you. So I will just sum up the main points. Like all the NORA situations, they are unique, and each situation is itself is a different topic, and it is the specialty. But getting familiar with the setup and the equipment is important, I think. And training the supportive staff, as all the speakers have insisted, is very, very important. And it is feasible at the institute practice, but for private practice also we can do some training, and it is really helpful. uh, I will suggest that taking little time before the procedure, or before providing anesthesia for the procedure, is very important, rather than spending time after the procedure and managing the complications. So to sum up, I think I will say that location for anesthesia can change, but not the standard care. Standard ASA monitoring and standard care should be uh, implemented. Now, vigilance or our guard should never go down. And while we are very much engrossed in our clinical management of the case, but we should always care for the NBM status, proper consent, and proper communication with the patient and the relatives. I think proper consent uh, is more important for our own safety. As medical legally, we do come under, that is, anesthesiologists do come under Consumer Protection Act. We are getting so many medical inquiries where anesthesiologists are at fault. Not at fault, but basically they lack documentation. So I think we should also concentrate on documenting the things. Uh, so I hope we all have gained insight in giving anesthesia to outside operating room anesthesia. And thank you all the speakers and chairpersons and all the delegates for joining this webinar. More than 75, I think 74 was there, and I'm including both of us on the one device. 75 delegates have attended this. So thank you very much. We will soon come with another webinar. Please be with us. Thank you.